So if you follow the channel, you probably already know, but about a week ago, I had the honor of sitting down with Stephen Bartlett for an episode of Diary of a CEO. That episode should be out by the time you're watching this, and I'll drop the link in the description down below. And before I get into anything else today, I just want to say this sincerely. Stephen and his entire team are an absolute class act. I thought I had done media spots before, but Diary of a CEO is hands down the most professional outlet that I have ever had the pleasure to work with. From the first email to the final handshake, every single person on that team made me feel welcome, respected, and like they actually cared about getting the content right. Stephen himself was even more thoughtful in person than he comes across on camera, which is saying something because he comes across pretty thoughtful on camera. The prep was meticulous, the questions were sharp, and the studio was gorgeous, and the whole experience was genuinely one of the highlights of my career so far. So to Stephen, Winnie, Zach, Cause, and the rest of the team, if you're watching this, which I'm gonna be realistic and assume you're probably not because you have a whole company to run, but just in case, thank you. From me, from Ronick, and from the whole channel. That was an experience of a lifetime. And while I'm being sincere, I want to say something to you. Yes, you, the person watching this video right now. Somewhere around the time when this drops, we should be crossing the 100,000 subscriber mark on this channel, and I don't take that lightly. Everything this channel is, everything it's built, everything it's going to become, the podcast appearance, the AUA talk, the reach, the platform, none of this exists without you. You are the reason that I get to do this. You have trusted me with your time, and time is the one thing that none of us gets back, and I take that responsibility very seriously. Our goal from day one has been to use this platform to do real good for real people, evidence-based, honest, occasionally stupid, but always pointed at making the information landscape a little less terrible for people trying to figure this stuff out. And we're just getting started. So thank you for every like, every comment, every share, every DM. Every time you passed a video along to a buddy who needed it. I see it, I appreciate it, and I'm gonna keep trying to earn it. Okay, so here's where the video actually begins. So this video is two things at once. First, it is a deep, detailed refresher on the exact legal status of peptides in the United States as of right now. What they are, how they got regulated, how they got deregulated, how they basically got banned, and how they're now, literally as of a few days ago, possibly on the road back. It's a messy story. It involves a fungal meningitis outbreak, a Supreme Court decision about breast cancer genes, a mysterious FDA website swap, a Joe Rogan appearance, a Federal Register notice, and a whole lot of biohackers stabbing themselves in the belly with vials they bought from websites that accept Dogecoin. It is a truly American saga. And second, this video is actually a preview of a talk that I'm going to give later in May. So consider this the public-facing version of that lecture. Same content, fewer slides, more profanity. You've been warned. Now, before we dive in, I need to ask you three things real quick. And I know every YouTuber says this, but hear me out because this video is gonna take about 15 minutes of your life, and it's genuinely one of the most important topics that we've covered on this channel. The first is that if you find this sort of content useful, smash the like button. The algorithm decides whether this video gets shown to 10,000 people or 10, and whether or not you click the thumbs up in the first couple of minutes. It's free, it only takes half a second, do it. Two is hit subscribe if you haven't already. This channel is where we drop long-form evidence-based content on men's health, peptides, PEDs, and the stuff most primary care doctors probably aren't comfortable talking about. There are a lot of people making videos on peptides right now, but most of them are selling peptides. I'm not. I'm a board-certified urologist with a men's health fellowship and a questionable nicotine dependency. Different vibe. And number three, drop a comment down below. Specifically, I want to know, have you used peptides? Are you using them now? Are you thinking about it? Or are you watching this video purely for entertainment purposes because you heard a urologist was about to try and explain the Administrative Procedure Act to a fitness audience? Whatever your answer, tell me. I read every single comment, as does Ronick. It tends to fixate on the ones that mention his editing, so if you really want to screw with him, try critiquing his B-roll choices. He gets all sassy.
I'll find their idea.
All right, let's get into it. Okay, quick refresher, and if you've watched our peptide deep dives before, I know, I keep doing this, but every time I post a peptide video, a couple new people wander in from TikTok or Reddit or wherever, and I just can't assume that everyone's up to speed. So here's the rapid fire version. A peptide is a short chain of amino acids linked together by peptide bonds. That's it. That is the entire definition. Amino acids are the building blocks of all proteins in your body. So you can think of peptides as the Lego instructions right before you finish the spaceship. They're intermediate. They're the middle child of the protein world. Your body already makes thousands of peptides. Insulin is a peptide, oxytocin is a peptide, vasopressin is a peptide, growth hormone releasing hormone, or GHRH, it's a peptide. These aren't all exotic compounds from a lab in Beijing, although God knows a lot of them are these days. At their point of origin, these are really molecules your body already uses to help run the show. As mentioned, anything 40 amino acids or shorter is classified as a peptide and regulated under the standard New Drug Application Pathway, the NDA. That's the same pathway as conventional small molecule drugs like Lipitor or Viagra. Anything longer than 40 amino acids is classified as a protein or a biologic, and it gets regulated under the Biologics License Application Pathway, the BLA. That pathway is significantly more expensive and significantly more restrictive. So why does this matter? Because the FDA has never, in the entire history of the agency, granted a compounding pharmacy a BLA license. Not once. Same framework as why you can't walk into your local compounder anymore and get HCG or FSH like you used to. Biologics don't get compounded, period. The cost of establishing a BLA-capable facility is conservatively somewhere between $80 and $150 million. So a compounder could apply for a BLA the same way that I could win the Arnold Classic next year. Not technically impossible, but essentially a guaranteed dumpster fire for everyone involved.
Become Mr. Olympia, I could be the best bodybuilder in the world. I could go to the moon if I wanted to, and then I'm gonna get rich.
And here's another key conceptual point that I want every single person watching this to internalize. Peptides are defined by their structure, not by their therapeutic effect. This is totally different from how we usually think about drug classes. Statins are defined by what they do. Beta blockers are defined by what they do. ACE inhibitors, again, defined by what they do. Peptides are defined by what they're made of. The metaphor that I used with Stephen Bartlett, and which I think actually landed pretty well, is that peptides aren't a drug class. Think of them more like a platform. They're like apps on your phone that are all running on the same operating system, which just happens to be your body. Insulin and oxytocin are both peptides, but they do wildly different things. They just happen to be written in the same biological language. Think of it like using the same programming language. But that biological language is going to matter a lot when we get to why a lot of these things are so hard to commercialize. And I want to kill one specific myth right at the top. Peptides are not new. They are not some fancy biohacker invention from the last 10 years. We've been making, injecting, and saving lives with peptides for over 100 years. Quick timeline, 1921 to 1922. Banting and Best isolate insulin at the University of Toronto. Insulin is a peptide. It's 51 amino acids, which you'd think means it's technically a biologic here in the good old US of A, but it actually got grandfathered in as a peptide since it was discovered before the FDA created that rule. This was the first therapeutic peptide, and it fundamentally changed the trajectory of human medicine. Type 1 diabetes went from a death sentence to a manageable chronic condition essentially overnight. It's impossible to overstate what a big deal this was. 1954, Vincent du Vignard synthesizes oxytocin in a lab at Cornell. This was the first time a biologically active peptide had been synthesized from scratch. He got the Nobel Prize for it the following year, which is how you know it's kind of a big deal. And here I am, Ronick, I just want my 100K subscriber plaque. Oxytocin, for those of you who don't know, is the molecule that makes you feel warm and fuzzy when you hug someone you love. It's also the molecule that causes uterine contractions during childbirth. Biology is not always subtle. 1982, recombinant human insulin made by Genentech and Eli Lilly just down the street hit the market. It was the first recombinant drug ever approved. We can now manufacture peptides at industrial scale instead of harvesting them from pig and cow pancreases, which, yeah, that's exactly how we used to do it. 1985 to 1989, Leuprolide and Goserelin are approved for prostate cancer and endometriosis. Leuprolide is a peptide, a synthetic nonapeptide to be specific. 9 amino acids, hence the nana. It is a GnRH agonist, and by continuously stimulating the pituitary, it paradoxically downregulates GnRH receptors, suppresses luteinizing hormone, and drops testosterone to castrate levels. This is now a foundational tool in urology. Every urologist in America has put a patient on Lupron at some point. This is our poster child, and we're going to come back to it later. Poster child, of course, because I'm a urologist, I'm biased that way. And then we have 2005 to the present day. GLP-1 agonists emerge. Exenatide, liraglutide, semaglutide, tirzepatide. These are also peptides. The whole Ozempic, Wegovy, Mounjaro, Zepbound revolution is a peptide revolution. The reason your aunt lost 40 pounds before your cousin's wedding is peptide pharmacology. As of today, there are roughly 100 peptide drugs approved globally, with many more in development. This is a mature, well-established, clinically validated class of molecules. We know how to make them, we know how to test them, we know how to dose them. We've been doing this for over a century. So anyone who tries to tell you that peptides are some cutting-edge, untested, unproven, probably dangerous new thing, they're either lying to you or more likely, they just don't know what they're talking about. Peptides as a category are extremely legitimate. What's new is which peptides we're talking about, how they're being sold, and the regulatory environment that they have to move through. Which brings us to the 19 peptides that have set the internet ablaze. Between about 2014 and 2023, compounding pharmacies in the United States could legally prepare a specific list of peptides for patients. The list wasn't infinite. They had to go through a nomination process, which we'll get to. But during that window, there were roughly 19 peptides that drove the bulk of modern clinical and biohacking interest. Let me group them for you because 19 peptides is a lot to throw at you all at once. Group 1 is what we're going to call the growth hormone and IGF-1 axis peptides. These are the anti-aging and potentially muscle-building darlings. CGC-1295, which is a GHRH analog. Ipamorelin, a selective growth hormone secretagogue. Ibutamoren, which is also known as MK677, which is also not technically a peptide because it's an oral ghrelin agonist and it's a small molecule, but it got swept up in the ban anyways. Then we've got Semax, which is sometimes pitched for lipolysis, but really it's more of a nootropic. And then PEG-MGF, which is pitched as a post-injury muscle repair compound. These are the peptides that the anti-aging clinics and telehealth bros have been shouting about for over a decade. Group 2 is tissue repair and regeneration peptides. BPC-157, which we've covered extensively on this channel. TB-500, the other half of the Wolverine stack. KPV, which we're about to record a video on and will be dropping soon. And then LL37, which is actually an antimicrobial peptide. And then we've got GHK-Cu, the copper peptide that dermatologists and biohackers fight over. Group 3 is going to be longevity, sleep, and nootropic peptides. Epitalon, pitched for telomerase activation and longevity, which is the kind of claim that makes me want to take a long sip of my energy drink and sigh audibly. Can't keep doing chronic. To be fair, Epitalon has shown the potential to actually regenerate the pineal gland, which would really help with regulating your circadian rhythm, which Rana gave up on his 20 years ago. So I am actually interested in it. We just need more data.
Sleep is overrated, Alex.
Yeah, as your continued existence proves.
Well, people have a view video referencing to sleep.
Everyone's gonna be like, sleep. Next video. And then we've got MOTS-C, pitched as an exercise mimetic. DSIP, delta sleep-inducing peptide. Cmax shows up here too because it's also pitched as stroke recovery agent. And then we've got Selank, which is a non-sedating anxiolytic, and Dihexa, which is a potent synaptogenic compound that, like MK677, isn't technically a peptide, but it got canned anyways. Group 4 includes immune, genitourinary, and alpha MSH peptides. This is the group probably most relevant to my fellow penis surgeon audience. And it starts out with something called thymosin alpha 1, which is actually approved in other countries for the treatment of both hepatitis B and hepatitis C. We've also got Kisspeptin 10, which triggers GnRH release and is a research tool of genuine GU interest, and melanotan 2, which activates melanocortin receptors MC1, MC3, and MC4. Melanotan 2 is also the one that gets marketed as an injectable tan, and also, incidentally, gives you raging erections that might just get you put on a list. I live near a school, I have to consider these things. But yeah, it is a wild compound. So those are the 19. Well, 17 technically if you don't count MK677 and Dihexa, 19 if you do. And then the FDA itself sometimes counts different numbers depending on how they're batching the CGC-1295 solve forms. But you're going to hear everything from 14 to 19 depending on which news article you read. And they're all talking about basically the same list of molecules, so don't let the numbers confuse you. But what matters is that from 2014 to 2023, these compounds were the engine of the modern peptide wellness market. Anti-aging clinics, longevity docs, functional medicine practices, sports recovery clinics, men's health clinics right here. Even some legitimate urology and dermatology practices use these peptides. And a lot of people were using these compounds on a lot of patients and getting good results. And then on a random Friday in September of 2023, that all changed. But before we can talk about that fateful day and what it happened and why it was such a big deal, we actually have to rewind the clock even more and go back to 2012. In the fall of 2012, a compounding pharmacy in Framingham, Massachusetts called the New England Compounding Center shipped contaminated steroid injections to clinics in 20 states. Don't get excited, they weren't those steroids. We're talking about injectable methylprednisolone acetate, the type of steroid your Mima needs for her rheumatism. But this particular batch of steroids was actually being used for epidural injections for back pain. And yeah, they were contaminated with a black mold called Exocerohilum rostratum. If that sounds like something out of a horror novel, that's because it basically was. We're talking upside down place level bad. 751 patients got sick and 64 people died because of this. This is one of the worst pharmaceutical disasters in modern American history. And almost nobody talks about it anymore because it's been overshadowed by the opioid epidemic, COVID, and every other horrible thing we've been subjected to. But it fundamentally changed how compounding is regulated in this country. When investigators went into the NECC facility, they found visible mold growth, bacterial contamination in the clean rooms, and what the prosecutor later described as, quote, a fungal zoo. The owner eventually pled guilty to manslaughter, 64 counts. So Congress had to act, back when they actually did things. In November of 2013, they passed the Drug Quality and Security Act, the DQSA. And the DQSA did something really important. It created a two-tier system for compounding pharmacies in the United States. Tier 1 is 503A. These are traditional pharmacy compounders. They fill patient-specific prescriptions. Your local compounding pharmacy, if your physician writes you a prescription for a custom-strength testosterone cream or a weird dose of liothyronine or whatever, that pharmacy is operating under 503A. They're regulated mostly by state boards of pharmacy, but with the FDA as backstop authority. Tier 2 is 503B, and they're way up here. These are actually called outsourcing facilities. They operate more like pharmaceutical manufacturers. They can compound very specific drugs in larger quantities without individual prescriptions for sale to hospitals, clinics, and surgery centers. They have to comply with current good manufacturing practices, which are super strict, and they're the same standards that pharmaceutical manufacturers operate under, CGMP, and they are directly regulated by the FDA. I've had the privilege to tour Empower Pharmacy's 503B manufacturing facility, and I will tell you, it is the most impressive industrial scale manufacturing facility I've ever seen, and I live in Lily's backyard. Now here's where peptides enter the picture. Under 503A, a compounding pharmacy can only prepare a bulk drug substance if one of three conditions is met. Number 1, the substance has a USP or NF monograph. Number 2, the substance is a component of an FDA-approved drug. Or number 3, the substance appears on what's called the 503A bulks list. For peptides at that time, back in 2013 and 2014, that were not already FDA approved and didn't have monographs, the bulk list was the only path. And so the FDA opened the nomination process in 2013. Industry submitted over 2,000 nominations. The FDA refined that down to about 740 substances and then categorized each one into separate buckets. Category 1 included substances that were still considered to be under evaluation, but they appeared to be safe enough that the FDA was going to exercise enforcement discretion. In plain English, category means we're still looking at this, but you can compound it in the meantime. Category 2 are substances that the FDA has determined present significant safety risks. Compounding these is prohibited. Full stop. And then we have category 3, which are substances that the FDA just didn't have enough information to evaluate. These are in regulatory purgatory and they're basically stuck there. For nearly a decade, from around 2014 to 2023, most of the popular peptides that we just went through were sitting in category 1, enforcement discretion, available at your friendly neighborhood compounding pharmacy with a doctor's prescription. I personally came into this space in 2018, which was right in the middle of what many described as the peptide golden era. And look, there was a lot of good that came out of that era. Patients with legitimate issues got access to novel therapies that the traditional pharma pipeline was just never going to develop. I've treated patients whose lives were immeasurably improved because of access to these compounded peptides. My life personally was changed in part due to MK677. Again, not technically a peptide, but that's not the point. So this really isn't a story with villains and heroes. Maybe. There's actually a pretty good argument to be made that there may have been a pharma lobbying boogeyman or boogeywoman behind the regulatory snafu that you're about to hear about, but what we do know for certain is that this is a story about a regulatory framework trying to do its best with a category of molecules that simply don't fit neatly into any of the existing boxes. And then the framework broke, in the sketchiest way possible. On Friday, September 29th, 2023, the FDA did something that, in my opinion, will go down as one of the strangest regulatory actions of the decade. They quietly swapped out a PDF on their website. That's it. That was the whole regulatory action. They updated the category 1 list. And when the updated list came out, 19 of the peptides that have been sitting in category 1 for years have been moved without any public hearing, without any press release, without any prior notice to category 2. Overnight, these compounds went from legal to compound to prohibited. With the stroke of a PDF upload, an entire sector of the wellness economy was made illegal. The justification the FDA provided was that these substances presented significant safety risks, but what they didn't provide was actual compound-specific justifications. They didn't even cite specific adverse event reports, and they didn't publish the data they're basing this on. They did not go through the Administrative Procedure Act's notice and comment rulemaking process, which is the legal mechanism by which these kinds of substantive decisions are supposed to happen. They just arbitrarily changed the list. Now, I want to be careful here. I'm not going to sit here and tell you I know exactly why this happened, because I don't. Nobody outside the FDA that was there at that time actually does. Now, there are theories, and some people think it could have been genuine safety concern. But some people, like this guy, think it was pressure from pharmaceutical lobbyists who are watching their patent-protected GLP-1 molecules get slowly chipped away at by compounding competitors and wanted to them over any way they could. Some people think that it was a career regulator making a unilateral call, and some people think it was all three. I genuinely don't know. But what I do know is that these compounds worked. I prescribed most of them, and patients have been using them safely for years. So when the FDA flipped that switch in September 2023, they didn't make the peptides go away. They couldn't make the peptides go away. These are chemically simple molecules that could be synthesized at any reasonably equipped lab in any reasonably developed country, and in some maybe not so reasonably developed countries. What they did instead is create the largest black market in modern America since Prohibition. Sorry, gray market to all my lab rat legion out there. But here's the thing about Prohibition. It's never actually worked. Not with alcohol in the 20s, not with cannabis starting in the 70s, not with MDMA or psilocybin or any of the other compounds we've tried to make disappear with a political decree. And guess what? It hasn't worked with peptides either. What happened after September 2023 was extremely predictable. The demand didn't evaporate, it just went underground. Within weeks, a whole new crop of websites popped up selling these exact compounds as research chemicals, not for human consumption. Totally for your lab rat. Again, shout out to my lab rat legion. I love you guys. And these sites shipped from China, Turkey, India, Moldova. They accepted cryptocurrency. They had names like researchpeptides.biz and peptidebros.io. They were not FDA regulated, not USP tested, and not sterility verified. And honestly, not really accountable to anyone. And patients who had just lost access to pharma-grade licensed pharmacy-prepared peptides started ordering them because the alternative was nothing. And simultaneously, the GLP-1 revolution kicked into overdrive. Semaglutide and tirzepatide went from niche diabetes drugs to cultural phenomena. Everyone on the planet had an opinion on Ozempic by early 2024. And because of the way these drugs work and the fact that they're peptides, the word peptide became a household term in the way it never had been before. People who had never heard of a peptide in their lives were now asking their doctors about peptides. And when their doctor said, "I'm sorry, we can't prescribe most of these anymore," they went online. And TikTok, of course, had already figured out how to monetize every piece of it. Influencers were pitching BPC 157 to rehab from injuries. Creators were walking viewers through their first self-injection. We had before and after photos of GLP-1 weight loss, pages upon pages upon pages of content promoting compounds that were, at that point, federally illegal to compound. And that gray market that the FDA created, it's now estimated to be worth billions of dollars. Kennedy has cited this number himself in interviews. Billions of gray market peptide money flowing to labs nobody can regulate for products nobody can quality control being injected by patients who nobody is supervising. If you wanted to design a policy to make peptide use more dangerous, less supervised, and less evidence-based, this would be that exact policy. So the obvious question, and one that gets asked in pretty much every comment section of every peptide video I've ever made, is if these compounds work, why doesn't some pharmaceutical company just run the trials, get them FDA approved, and then sell them like regular drugs? Great question. And there are two reasons, and we've got to walk through both of them. Reason one is the patent problem. In June of 2013, the Supreme Court decided a case called Association for Molecular Pathology versus Myriad Genetics. Myriad was a biotech company that held patents on the BRCA1 and BRCA2 genes. And these are genes that, when mutated, dramatically increase a woman's risk of breast and ovarian cancer. They also happen to increase a man's chance of developing prostate cancer. And Myriad's patents gave them an effective monopoly on BRCA testing, and they enforced that monopoly very aggressively. They sent cease and desist letters. They sued competitors. They charged over $3,000 per test. The Supreme Court's ruling was unanimous, 9-0, and it was written by Justice Clarence Thomas. And the core holding was this: a naturally occurring DNA segment is a product of nature, and it is not patent eligible merely because it's just been isolated. In other words, if it exists in nature, you can't patent it. You can only patent something that you actually invented. Now, pause for a second and think about why this is relevant to peptides. BPC 157 is a partial sequence derived from a protein naturally found in human gastric juice. TB500 is a synthetic fragment of thymosin beta-4, which is a naturally occurring human peptide. GHK-Cu is a naturally occurring copper-binding peptide that circulates in your bloodstream, while KPV is a 3-amino acid fragment of alpha MSH, which your body already makes. Every single one of these is, at its core, a naturally occurring human molecule, which means under Myriad Genetics, none of them are patentable as composition of matter claims. And without patent protection, there's no commercial pathway, because here's the brutal economics of drug development. Getting molecule through phase 1, phase 2, and phase 3 clinical trials to FDA approval costs somewhere between $1 and $2 billion, with a B. Nobody spends $2 billion on a trial program if the day the drug is approved, anyone in the world can legally copy it and sell it cheaper. You don't get a return on your investment, you go bankrupt. This is not a hypothetical. This is exactly why there is no commercial BPC 157. Nobody is going to fund a $2 billion trial for a compound they can't protect. Now, the GLP-1 drugs sidestep this by being modified novel forms. Semaglutide is not endogenous GLP-1. Native GLP-1 has a half-life of about 2 minutes, which makes it useless as a once-weekly injection. Semaglutide has been engineered with specific amino acid substitutions and a fatty acid side chain to extend its half-life. Tirzepatide is a dual GIP and GLP-1 agonist that doesn't exist in nature at all, and these are patentable, and that's why Novo Nordisk and Eli Lilly can afford to sell them. So in theory, Pharma could do the same thing with BPC 157 or TB500. Make a modified version, patent it, run the trials. But here's the catch. Unlike native GLP-1, which has a 2-minute half-life problem, these native forms seem to work just fine as is. So why spend $2 billion developing a modified version of BPC 157 when the plain Jane vanilla version already does what it needs to, and anyone with an internet connection can already buy it from a gray market supplier? The economic incentive isn't there. Reason 2 is the disease state problem. FDA approval requires a drug to target a specific disease state. That's how the regulatory framework is structured. You have to say, this drug for this condition in this patient population at this dose. You have to run a phase 3 trial showing that your drug treats that specific condition better than placebo or standard of care. And that whole paradigm is part of the reason why American healthcare is really more sick care than focusing on health and wellness, which is a whole other rant that I'm not going to get into right now. And so many of the peptides that we've been talking about are marketed for things that aren't formal disease states: tissue repair in an aging athlete, longevity, general wellness, cognitive enhancement, vague functional improvements. These aren't ICD-10 codes. The FDA doesn't have an approval pathway for making you feel better. And if that isn't a big glaring banner for how healthcare in the US, again, is totally screwed, I don't know what is. Which means even if the patent problem got solved, you'd still run into the indication problem. What disease are you treating with GHK-Cu? Inflammatory aging? That's not a real disease, although I feel like it is every time I wake up and look in the mirror. It's a concept, and you can't run a phase 3 trial on a concept. Put those two problems together and you get exactly what we have now. Strong therapeutic interest with limited commercial pathway, and then a massive gray market that is formed to fill the vacuum. The system isn't broken because the FDA is evil. The system is broken because our drug approval framework was built for our pharmaceutical industry that made money by patenting novel molecules to treat discrete diseases, and peptides just don't fit that mold. Okay, that brings us to now. Through 2024 and even into 2026, the peptide reclassification issue just simmered. The FDA did remove a handful of substances from Category 2 in September 2024 after the nominators withdrew their nominations: CJC1295, Ipamorelin, AOD 9604, thymosin alpha-1, and Selenk. These got bumped out. But they didn't go into Category 1 where they could be made again. They just went into a sort of regulatory limbo while PCAC meetings happened in October and December of 2024. And at those meetings, the committee mostly voted against recommending these substances for inclusion into the 503A bulks list, which again, as we talked about, is where they have to be if they're going to be manufactured. So nothing really changed. The gray market kept growing, biohackers kept injecting, and then came February 27th, 2026. On that day, Health and Human Services Secretary Robert F. Kennedy Jr. appeared on the Joe Rogan Experience, episode 2461, and he made a pretty big announcement. He said on Joe's podcast that the FDA was going to move approximately 14 of the 19 Category 2 peptides back to Category 1. Now, this was not a regulatory action. This was a policy announcement made in a 3-hour interview with an MMA announcer / podcaster / comedian. Nothing actually had happened yet. Kennedy just signaled intent, and that's all. For the next 6 weeks, everyone in the compounding space, the peptide industry, the biohacker community, the regulatory law firms, everyone was just holding their breath, waiting to see if the FDA was actually going to follow through on this, or if it was just going to evaporate the way a lot of politicians' statements have evaporated in the past. Well, it definitely didn't evaporate. On April 15, 2026, the FDA issued a Federal Register Notice, docket number FDA 2025 N6895. That notice announced the formal referral of 7 peptides to the Pharmacy Compounding Advisory Committee, as I mentioned, the PCAC, for review at a meeting scheduled for July 23rd and 24th, 2026. Simultaneously, the FDA administratively removed 12 peptides from Category 2, effective 7 days from publication. And that was the regulatory action everyone was looking for. It wasn't the podcast, it was the Federal Register Notice, published April 16th, effective April 23rd. Coincidentally, I learned about it while on the airplane, going to go interview with Stephen Bartlett. No pressure. Future Alex popping in here with some rumors that, if true, could radically change GLP-1 peptide access in America, potentially forever. Yeah, I know, we just finished this whole video, we wrapped, Ronick started the edit, I came home, unpacked, slept in my own bed for the first time in days, hugged my kids, drank a Victory White Monster, and I thought I was done. And then the internet did what the internet always does, which is wait exactly long enough for me to feel accomplished and then drop a bomb in my lap, which in this case was Friday. So yeah, I'm recording this addendum in a different hoodie. Ronica's probably got to figure out where to put this in the original video. Sorry, Ronica, I owe you a free vial of testosterone.
Bet.
I'm kidding. Please don't report me to the medical board. Let's get into it. Okay, so here's what happened. On April 16th, a tweet dropped from an account claiming to have spoken to an HHS insider. The allegations were wild. Eli Lilly is actively, aggressively pushing the FDA and the HHS to reclassify GLP-1 peptides, semaglutide, tirzepatide, and in particular, their next generation compound retatrutide as biologics rather than drugs. That single post caught fire. Within 72 hours, it had been amplified by a half dozen other accounts with serious reach in the compounding and biohacking space. By the weekend, it was everywhere on my feed. People were asking me about it in the comments, and my inbox was full of it. Which is different than how my wife says that I'm full of it. Now, let me give you the fair assessment. The specific claim that there is an HHS insider feeding information about active lobbying pressure is single source, one tweet, not independently corroborated, and I can't tell you whether that specific allegation is true or not, and I'm not going to pretend like I can. But here is what is absolutely, verifiably on the record true, and this is the part that matters. Eli Lilly, the guy's just down the street from where I'm recording this, is suing the FDA to have retatrutide classified as a biologic rather than a drug. That isn't a rumor, that isn't a tweet. That is a federal lawsuit filed in the Southern District of Indiana on September 3rd, 2024. Eli Lilly and Company versus Becerra, case number 124CV01503. You can look it up. And here's the dispute. Retatrutide, which is Lilly's next-gen triple agonist and one that we've talked about a lot on this channel, check the video up above, hits GLP-1, GIP, and glucagon receptors. And it does this with a main backbone of 39 alpha amino acids. Under current FDA interpretation, you need more than 40 alpha amino acids to qualify as a biologic. 39 is a drug, 41 is a biologic. That one amino acid is the difference between two of the biggest regulatory universes in modern pharmaceuticals. And so Lilly is arguing that retatrutide actually has 41 amino acids if you count a second small side chain attached by what's called an isopeptide bond, two non-alpha amino acids hanging off the main structure. Count those and retatrutide crosses the threshold. The FDA said no, alpha amino acids only. Retatrutide is a drug. And then Lilly sued. And on September 30th, 2025, a federal district court judge in Indiana, my own backyard, sided with Lilly. Partially. The court vacated the FDA's classification of retatrutide as a drug. The agency now has to go back and reconsider, and the case is now on appeal to the 7th Circuit. In other words, this fight is live and going on right now. The rumor about Lilly pushing hard on this probably isn't even news. They've been pushing hard on this in federal court for 19 months. Whether there is also an HHS side push happening behind closed doors, I can't verify. But the broader strategy, the intent, and the legal architecture, all of that is public record and undeniable. So why does Lilly care? Why is Eli Lilly, one of the largest pharmaceutical companies on the planet, spending who knows how many millions of dollars in legal fees to argue about two amino acids? And why should you care about it? Because of how much money is on the line. And I'm going to walk you through the math, because once you understand it, you're going to understand everything. When a pharmaceutical company gets a new drug approved under the standard small molecule pathway, which is the one we talked about in the main video, they get 5 years of exclusivity under the Hatch-Waxman Act. 5 years. Now, there's some nuance and exceptions there, but that's what we're looking at in general. So after that, generic manufacturers can file an abbreviated application and start making cheaper copies. And once those generics hit the market, prices typically drop by 80 to 90% within 12 months, which is the entire reason why Viagra, which used to cost north of $70 a pill, is now basically free. Sildenafil went generic in 2017, Cialis went generic in 2018. The patents expired, the generics flooded in, and prices collapsed. So American men with erectile dysfunction could finally afford to have sex again. Free market capitalism, kind of beautiful when it works. But biologics get a completely different deal. Under the Biologics Price Competition and Innovation Act of 2009, the BPCIA, biologics get 12 years of exclusivity. 12, not 5. And even after those 12 years, biosimilars, which are biologic versions of generics, do not collapse prices the way traditional generics do. The median time to actual biosimilar competition in the US is over 20 years. 20! And here's the kicker, and the one that really matters for this conversation. Compounding pharmacies cannot compound biologics. Full stop. They need a biologics license application, a BLA, which again, we covered in the main video, costs somewhere between $80 and $150 million to establish and has never in the history of the FDA been granted to a compounding pharmacy. So the moment a molecule gets classified as a biologic, the 503A and 503B compounding pathways are closed to it forever. End of discussion. So just think about what happens if Lilly wins this fight. Retatrutide and potentially semaglutide and even tirzepatide by extension would get 12 years of exclusivity instead of 5. Biosimilars would be delayed for decades. Compounding pharmacies would be permanently locked out. Medicare negotiation leverage would be diminished, and the price of GLP-1s, which is already destroying household budgets and insurance formulators across the country, would stay at pharmaceutical company pricing levels essentially forever. This isn't speculation. This is the basic architecture of US drug regulation applied to a very specific chemistry argument about whether a couple of side chain amino acids get to count. 2 amino acids, billions of dollars, maybe hundreds of billions over the lifetime of the GLP-1 category. And here is why I am taking this seriously and why you should too. Because we have seen this exact same playbook run before. In urology, in the male fertility space, on a hormone my patients have depended on for decades. And that hormone, that glycoprotein, is HCG, human chorionic gonadotropin. HCG has been around since the 1930s as a purified hormone and since the 1950s as an FDA-approved injectable. For literally almost a century, HCG has been a workhorse medication in men's health. In urology specifically, we use it for low testosterone, for fertility preservation, for testicular atrophy during testosterone replacement, for delayed puberty, for undescended testicles in boys. It is a mainstay. Every urologist, every endocrinologist, every men's health doc in America has written dozens, hundreds, thousands of prescriptions for HCG, or at least they did up until March 23rd, 2020. Before that time, HCG was classified as a drug. It could be compounded by 503A and 503B pharmacies. A 10,000 unit vial of compounded HCG cost somewhere in the range of 50 to 80 bucks. It was available, it was affordable, and it was everywhere. But then, on March 23rd, 2020, a provision of the Biologics Price Competition and Innovation Act of 2009, the same BPCIA we just talked about, took effect after a 10-year transition period. That provision transitioned HCG, along with FSH, LH, and a handful of other hormones, from drug status to biologic status, overnight. So what happened? 80% of the compounding pharmacies that had been making HCG had to stop overnight. Patients who had been paying $50 for a vial suddenly had to pay 5 to 7 times more than that for the brand name versions, including Pregnyl, Novaril, or Avidril. Some of those brands went into shortage almost immediately because they just couldn't scale to replace the compounded supply. And critically, for men's health specifically, and this is the part that makes me really mad, there is no FDA-approved HCG indication for adult men with hypogonadism or male fertility issues. So now we're using a branded, biologic, 5 times more expensive product off-label and dosages that don't make sense for an indication the FDA has never even considered because we have no other option. The population that got hurt? Young men trying to build their families, hypogonadal men trying to preserve fertility, men on TRT trying to keep their testicles somewhat functional, boys with undescended testicles whose families are now paying a fortune for something that used to cost basically nothing, men whose marriages depend on being able to have a child. That population, my patients, hurt by a regulatory reclassification that no patient ever asked for and provides no meaningful safety benefit because HCG is one of the most well-characterized hormones in medicine. The excuse that HCG is a biologic because it's a complex glycoprotein derived from a biological source. Sure, fine, but guess what? We've been safely compounding it for decades. The reclassification didn't make HCG safer, it made it more expensive and less accessible. So guess what? That's the playbook. That's the template, and it is exactly what Lilly is trying to do with retatrutide, and by extension, potentially semaglutide and tirzepatide if the door opens wide enough. So I encourage you, if you care about this, and by this, I mean whether or not GLP-1 medications will stay at their current price point, whether biosimilar competition will ever meaningfully arrive, or whether compounding pharmacies will even have the option to make these drugs during the next shortage cycle, you can actually do something. Call your senators, call your congressional representative, tell them that you're a constituent, and tell them that you're paying attention to the retatrutide classification fight. Tell them that you oppose the quiet expansion of biologic status to compounds that have historically been regulated as drugs. Tell them that reclassifying small molecule scale peptides as biologics simply because a pharmaceutical company wants longer exclusivity is bad public policy. You don't have to be a pharmacist or a doctor to make that call. You don't have to explain what an isopeptide bond is. You just have to say this: I'm a constituent, I care about GLP-1 drug pricing, and I oppose reclassifying GLP-1s as biologics. So that's it. That's the ask. 5 minutes of your time. 5 minutes that actually matters, because this kind of technical regulatory fight almost always gets decided by whoever is paying attention. And right now, the only people that are paying attention are the pharmaceutical companies and their lobbyists. All right, there you go. That's the addendum, the rumor, the lawsuit, the HCG parallel, and that's the ask. So is Eli Lilly actively lobbying HHS behind closed doors the way the April 16th tweet claimed? I don't know. I can't verify it. If someone shows me independent corroboration, I will totally update this in another video. But the broader strategy that the tweet described, that's absolutely happening. It's in federal court, in the public, with real legal filings and real stakes. If Lilly wins this fight, GLP-1s stay expensive forever, compounders stay locked out, biosimilars are delayed by decades, and the HCG disaster gets replayed at a scale about 100 times bigger. And ultimately, we're the ones that end up paying the price. Now, back to our regularly scheduled programming. And Ronick, sorry again for the different hoodie. I owe you 2 free vials of testosterone. Kidding. Catch you in the main video. The 7 peptides going before the PCAC on July 23rd and 24th break down like this. On day 1, July 23rd, we've got BPC 157, KPV, TV500, and MOTS-C. And then on day 2, July 24th, we've got amideltide, aka delta sleep-inducing peptide, or DSIP, Semax, and epitalon. And a second group of compounds is expected to follow in later PCAC meetings. GHK-Cu, dihexa, ibutamoren, melanotan-2, LL37. These haven't been formally scheduled yet, but they're in the pipeline. Now, I have a theory, and I want to be clear about this. This is just speculation on my part. Nobody at the HHS has told me this. This is just what it looks like from an outsider who pays attention to this space. Throughout 2025 and into 2026, the FDA under Dr. Marty Makary has led a genuinely brutal enforcement crackdown on compounding pharmacies that have been making GLP-1 products. Now, compounded semaglutide and compounded tirzepatide had exploded in popularity during the shortage periods because the commercial guys just couldn't keep up with the demand. And so compounders were making money that Lilly and Novo Nordisk believed belonged to them. So the FDA, under pressure from lobbyists, I believe, shut that down hard. We're talking warning letters, enforcement actions, subpoenas, constant inspections. It was not subtle. It was mob enforcer level. So why does this matter? Because it was likely the quid pro quo promised by the Trump administration to get his Trump RX initiative off the ground, which is positioned to sell brand name GLP-1s directly to consumers at a discount, cutting out compounders entirely. And from that angle, restoring access to peptides is a lot like extending an olive branch. Hey compounders, we took your GLP-1 business, but here's your BPC 157 business back. Now, please shut up, go home, and stop lobbying Congress. You're welcome. Is this exactly what happened? I don't know. I can't prove it. I'm not in those meetings. But the timing is suggestive, and the regulatory analysts in the compounding space have been saying more or less the same thing. Okay, so here's the part where I need to temper expectations, because there is a tremendous amount of misinformation on social media right now suggesting that BPC 157 is going to be on pharmacy shelves in August, and it's not, and here's why. The PCAC meeting in July is an advisory committee meeting. The PCAC's job is to review the data, hear from nominators, listen to public comment, and then vote on a recommendation. That recommendation is not binding. The FDA can follow it or not follow it. Historically, the FDA follows the PCAC recommendations most of the time, but not always. And even if the PCAC votes favorably on every single peptide, the FDA accepts every single recommendation, there's still a legal process that has to happen before anything can really change. And that process is called notice and comment rulemaking. It's governed by the Administrative Procedure Act. It requires the FDA to publish a proposed rule in the Federal Register, open a public comment period that typically lasts 30 to 60 days, review and respond to those comments, and then issue a final rule. All of that takes time. And so in the best case, we're looking at maybe 12 months if we go on precedent alone from PCAC vote to final rule. Now, again, this FDA has moved lightning fast to other approvals, so maybe we'll be surprised. In the more realistic or worst case scenario, maybe 18 to 24 months. So even with a maximally favorable PCAC outcome in July 2026, compounders likely won't get full legal access to these peptides until late 2026 if things move lightning fast, but honestly, it could be early 2027 or later. July 2026 is a milestone, but it isn't the finish line. And on top of all that, let me underline one more time what Category 1 reclassification actually means. It means that these peptides can be legally compounded by licensed pharmacies with a physician's prescription under enforcement discretion, while they remain under FDA evaluation. Which means, no, these things are not FDA approved. It does not mean proven safe and effective in phase 3 trials. It doesn't mean standardized dosing, and it certainly doesn't mean insurance coverage. It means compounding eligibility, which is real and valuable and a meaningful step towards patient safety over the current gray market nightmare, but it isn't the same as approval. And I want that to be clear because I have watched people online get this wrong for months, if not years at this point, and it's driving me crazy. So what do we do with all of this? If you're a clinician watching this, here's what I'm going to be telling the room at AUA in May, and here's what I'm going to tell you. I've got 4 things. One is educate yourself now. The regulatory landscape is shifting underneath us. PCAC review begins in July. If reclassification proceeds, a lot of patients are going to walk into your clinic in late 2026 or 2027 asking about peptides if they aren't already. You don't have to become an expert, but you should at least know what these compounds are, what the evidence does and does not show, and where the risks actually lie. You should also know what your patients are already doing, because I promise you, a non-trivial fraction of them are already using these things, including a lot of the people watching this channel. Number two is providers need to counsel patients on gray market dangers. Patients sourcing so-called research chemicals face adulteration, endotoxin contamination, unsterile manufacturing, and zero quality control. Again, it's like gas station sushi. You can get lucky and it could be fine, or it could be terrible. If your patient tells you that they're using a compound, don't shame them. Don't reflexively just tell them to stop. Instead, ask them where they're getting it. Talk about the real risks. Redirect them towards legitimate channels when those channels become available. Meet them where they are. 3, advocate for rigorous human trials. Some of these compounds have genuine therapeutic promise. Thymosin alpha-1 has enough data to justify fast-tracked phase 3 trials. AOD 9604 is a plausible obesity adjunct. And these are molecules that deserve real clinical investigation, and the compounding framework isn't a substitute for that. Reclassification is a pressure valve. It's not a substitute for evidence. And finally, we've got number 4, prescribe judiciously when legal. If and when these peptides return to category 1, you'll be in a good position to prescribe them, and that's a privilege and responsibility. Don't be the guy writing random scripts for anyone who just walks in the door. But also, don't be the guy who reflexively refuses because these compounds don't fit neatly into your traditional pharma box, and, because no one brought you free lunch to talk about them. Use your clinical judgment, apply the evidence you have, counsel honestly, and monitor carefully. And if you're a patient watching this, my advice hasn't changed. Talk to your doctor. If you're already using these compounds, just be honest about it. And if you're thinking about using them, understand that as of today, literally today, we are still in the category 2 era for most of them. That will likely change, but it hasn't changed just yet. I believe in bodily autonomy. I believe adults have the right to make informed decisions about their own health. What I care about is that those decisions are informed and that the information you're using to make them is accurate. That's the whole mission of this channel. And that's the whole reason that I went on Diary of a CEO. And it's the whole reason that I'm about to stand up at AUA in May and try to explain this to a room full of urologists who, understandably, probably already think I'm crazy. But if this video helped you understand the situation better than you did 15 minutes ago, then I've done my job. And if Ronick actually managed to edit this video down to 15 minutes, then he's done his job. All right, we made it. 15,000 word Federal Register notices summarized into one YouTube video. You're welcome. If this video helped you, do me a favor, smash that like button. Seriously, I know every YouTuber says it, but the algorithm genuinely runs on it, and this is a niche topic that most channels just are too scared to cover. Your like is how this video finds the next person who needs it. Subscribe if you haven't. This channel is where I drop long-form content on peptides, PEDs, men's health, and all the stuff that your doctor probably isn't comfortable talking about. It's evidence-based, honest, and occasionally profane, but it's always coming from a place of genuine care about getting it right. So drop a comment, tell me, were you using any of these peptides before September 2023? And are you using them now? Are you waiting for them to come back? What's your situation? I want real stories. I want to know what the last 2.5 years have looked like from your side. If you want to watch the Diary of a CEO interview, the link is in the description. Steven and his team did an incredible job. If you want to see me try to explain all of this to a room full of urologists live and in person, I'll be at the AUA annual meeting in Washington, D.C. come this May. Come find me, say hi, tell me you watch the channel. I'll be the guy sipping an energy drink, popping a zenny in a poor-fitting blazer. And to all of you, seriously, from the bottom of my heart, thank you for watching. Thank you for subscribing. Thank you for the comments and the DMs and the stories. This channel exists because you exist, and I don't take that for granted. To Steven and the whole Diary of a CEO team, thank you again. It was an experience of a lifetime, and I owe you one. And to my 3 urology buddies who actually watch these videos, hi guys, I'll see you in May. I'm Dr. Alex. Stay curious, stay skeptical, and as always, proceed accordingly.